So good morning, everyone. Thanks for the introduction. And I'll start off with a brief outline of what I'll be speaking about this morning. I'll begin by giving a very brief introduction of QiPCM and then discuss what we've done to enable personalized dosimetry for the Netprt trial. We'll go through what the dosimetry report generation process looks like, and then I'll present a sub-study we performed to evaluate whether we could decrease the amount of imaging required to perform individualized dosimetry, thereby making it more cost-effective for the hospital as well as less burdensome for the patient. So first of all, QiPCM stands for Quantitative Imaging for Personalized Cancer Medicine, and we're an imaging core lab run out of Technion Institute at UHN. QiPCM has three main aims. First is to anonymize and centralize DICOM imaging data for multi-site clinical trials, and then provide a secure means for study investigators to access their imaging and perform any necessary analysis or review. Secondly, we have developed the procedures and tests to help provide clinical trials with the best quality imaging data and results via things like scanner QA and assisting in imaging protocol development. And finally, we have our support services and image analysis team, which can perform image analysis for trials, as well as in the case of the Netprt trial discussed today, they can develop the tools necessary for those trials to perform their own analysis. These three aims are exemplified here in this diagram. On the left, you have the remote institutions scanning patients and then sending their images into QiPCM via the QiPCM CTP pipeline. Those images are anonymized before they leave the site, and then they come into our image QC holding area, where they're reviewed for adherence to trial protocol, as well as confirm any PHI hasn't inadvertently made it through. These images are then stored on our QiPCM packs, where they're segregated by trial. On the right, we then have our remote investigators logging into the system via our virtual desktop infrastructure, where they can view and analyze their images from their trials and only their trials. And finally, we have the consulting and support team from QiPCM responsible for things like scanner QA, image analysis, and application development. So here are just a few of our key performance metrics. We have a total of 54 trials on the platform, of which 37 are currently active. This accounts for about 4,188 patients and almost 19,000 studies. The CTP pipeline has been used to send images into QiPCM from 46 different hospitals across the world, predominantly in North America, but with a handful of sites in Australia and recently Europe. So now that I've discussed a little bit about what QiPCM are, I'll explain the Netprt trial and how QiPCM was involved in terms of how to support it. So the Netprt trial is a prospective phase 2 single-arm multi-center study of the efficacy and safety of lutetium-177 octreotide treatment in patients with somatostatin receptor positive neuroendocrine tumors. The study is led by Dr. Rebecca Wong out of the Princess Margaret Cancer Center in Toronto. Lutetium dotatate, or LuDOTA, is a theranostic agent which binds the cell surface somatostatin receptors to provide treatment via radiation. Prior to being enrolled, each patient will receive a gallium-68 dotatate scan, as you can see here on the left, which must be reviewed by a tumor board to determine eligibility based on the presence of somatostatin analogs. Then 190 patients will each receive up to 4 cycles of LuDOTA therapy with their prescribed dosages based on individualized dosimetry. What we mean by individualized dosimetry is that since lutetium emits both a beta particle which can treat the tumors via radiation, as well as gamma radiation, it can be imaged by SPECT cameras, which allows us to determine how much dose the patient received to both their tumors and organs at risk. So on the left is a gallium-68 image, and on the right is a SPECT image of lutetium dotatate. So to address these challenges and provide a solution, QiPCM started by configuring CTP pipelines at each of the 4 institutions involved in the trial, such that all their images would be anonymized and sent to our clinical trial packs. QiPCM then reviews these images to make sure they adhere to the dosimetry guidelines for the SPECT images, and then we're able to then send them to our clinical trials packs. We're then able to develop a LuDOTA dosimetry extension for MIM, which can perform the cycle-to-cycle dosimetry and produce reports for the physician and physicist. So the individualized dosimetry process is a very complicated process you can see here, and many of the newly approved theranostic agents just prescribe a fixed dosage across those 4 cycles because of that reason. One of the aims of the Netprt trial was to demonstrate the effectiveness of using individualized dosimetry to improve those outcomes and reduce those adverse events, to show that it's really worthwhile even due to the complexity. I won't get too much into that today because that's the study results from Dr. Wong's trial, and I don't want to steal her thunder, but she's got a manuscript that she's trying to release on that now. So after a patient is treated with lutetium dotatate, they receive SPECT CT scans at 4, 24, and 72 hours post-treatment. These images are anonymized and sent to QiPCM where they're checked for accuracy. They're then provided to a radiation therapist to contour the organs at risk and tumors. The contours are then reviewed by the radiation oncologist before the dosimetry report is generated. And then that report is reviewed by a medical physicist for sign-off, and the next cycle's dosage is ordered. So you can see there's quite a few steps in the process. So I'll give you a very abridged version of what the radiation therapist and radiation oncologist have to do in order to generate these reports. So the dosimetry calculations are based on the quantitative SPECT images. You can see them here. And to do that, a 2-centimeter region of interest is placed on both the organs of risk, so the kidneys on both left and right, as well as on the bone marrow. And then these regions, they also contour any obvious tumors. We don't actually contour every tumor, but just a few to track along the process. So a liver lesion, an extrahepatic lesion, and then we contour the entire liver as well. These contours are then copied over to the 24-hour scan, where the physician or the therapist can adjust the contours. And then once those are, and clean anything up that's necessary. And once that's all done, they're set to review them. Those contours are then, well, they save the contours as well. And then it's passed over to the radiation oncologist. The radiation oncologist will then enter all the dose information, so how much the patient had injected, on what time and date, as well as their name, and then they'll run the plan. And MIRD-based dosimetry will then be applied to each of these tumors to determine how much dose was received, and they'll get a nice dosimetry report. So for the Netprt trial, patients have a renal tolerance of 23 gray, but we actually set it to 22 just to provide a margin of error. And this is just a quick example of what they'll see when they get their dosimetry report. So we'll see so far this was after 3 cycles for this patient. They'd had 17.7 gray received to their left kidney and 16 gray to the right. And we can see how much is left in their kind of dose budget. We then look back at the previous 2 cycles and determine how sensitive the kidneys were to the actual injected dose, and propose the dosimetry for the next, or the proposed injected dose for the next cycle. That's then signed off by both the physicist and the radiation oncologist before it's provided to the sites. So we've done that successfully for about 154 patients to date. And now that I've described the basic process used, I'll discuss some of the work we've done recently to try to improve this process by reducing the number of imaging sessions that a patient can receive without affecting their treatment. This is work that was just presented at ASTRO a couple of weeks ago. And as you can see, there were quite a few collaborators from all 4 clinical sites at Sunnybrook, London Health Sciences, as well as Juravinski and Hamilton. So in the Netprt trial, 152 patients were accrued from the study between the 4 sites between August 2016 and May 2020. Of these patients, 102 completed all 4 of their cycles of treatment. However, of those, only 81 patients completed all 12 SPECT sessions. So this means they had all 3 imaging sessions on all 4 cycles. These 81 patients are kind of the gold standard patients that we're going to deal with in this analysis. In order to determine whether it'd be safe to remove one or more of the imaging time points, we needed to simulate the effect of different fitting algorithms on the patient data we've received. So the simplest way we fit this data, so ultimately, just to back up for a second, this is what we get from our dosimetry, basically, well, from the SPECT imaging. We'll know that there was a certain amount of activity at 12 hours, or at 4 hours, 24, and then 72. And we then have to fit a curve to that and determine the area under that curve, which is how we determine the amount of dose to the organ. So we can do this in a number of different ways. The first is using the single exponential fit, seen here, where we do a linear fit between 0 and 4, and then 4 and 24, and then a single exponential curve, the remainder, with the 24, 72, and infinity time point. Or we can do a more complicated way, and this is kind of the standard in the industry, which is to do a simplified bi-exponential form. So in this case, we'll do an exponential which incorporates both the increase and the decrease. And this is what we consider the gold standard for our analysis. And then we start looking at what happens when we start removing a data point. So what if we only scanned the patient at 4 and 72 hours or at 24 and 72 hours? What would happen to our fits? So if we do a single exponential fit, we see we need to then connect from 0 to 24 in one of these two ways, as well as fitting the rest of the curve. And if we do a bi-exponential curve, we need to see how will the fit be affected where we either miss the 4-hour point or miss the 24-hour point. And recently as well, some other groups have provided the insight that we might actually be able to get away with just doing one time point dosimetry. And this means they use a population-based curve as well as the value of your data at 72 hours, at the 72-hour time point, and just use a simple formula to calculate the dose. So now we come to the results of this study. In this slide, we look at the impact of removing either the 4 or 24-hour time point while applying the simplified bi-exponential fit, as well as removing both the 4 and the 24-hour time point and just using the 72. We didn't include the effects here of removing one time point from the single exponential fit, as it wasn't successful at producing comparable results to the bi-exponential. These figures depict the calculated dose obtained for each cycle as compared to the gold standard. So the gold standard dose is on the x-axis, as well as the calculated dose when using the bi-exponential fit, but when removing either the 4 or 24-hour time point. We can see when removing the 4-hour time point, about 5.3% of the points fell outside of 1 gray, while 6.5% fell outside removing the 24-hour time point. Fortunately, there was no bias here in terms of the data, so there was an equal number of points above and below, slightly more above potentially here and slightly more below potentially here. Unfortunately, the one-time point dosimetry method did show a significant bias and resulted in significant overestimation of the dose to the kidneys as compared to the gold standard. As we can see, many of the values fell below the curve. Well, some of the values fell below the curve, which were actually closer to accurate, but you can see the actual slope is about 16% high, which was concerning to say the least. So where the previous panel illustrated the impact of removing 1 or 2 time points on the calculated dose, this figure shows what the impact would have been if we use those calculated doses to prescribe the subsequent fractions of lutetium. So if we pretended basically we only had done the imaging at 4 and 72 or 24 and 72, what would we have prescribed for the next cycle? And we can see encouragingly, when we only remove 1 time point, the impacts on the prescribed dose are relatively minor. Though there are significant cycle-to-cycle variability, the overall cumulative injected dose remained well in line with the gold standard. This is especially true when removing the 24-hour time point, in which case only 1 out of 81 patients would have received an injected dose more than 15% off. So you can see there are a few outliers at the dark curve, which is removing the 4-hour time point. But when looking at this curve here, this is kind of the important one. There's only the 1 time point that's outside of 15%, and even that's only outside by about 16%. Conversely, on the right, we see the impact of prescribing our dose when using the 1 time point dosimetry method. If we followed the 1 time point dosimetry predictions, patients would have had a significant reduction in total injected dose, with a mean decrease of 14.4 millicuries per cycle and 57.7 millicuries over the course of the treatment. So in this third figure, we can see the predicted impact of the dose to the kidneys, as well as performing as a result of performing 2 time point dosimetry. We didn't continue with the 1 time point dosimetry after the previous curve's results. When removing the 24-hour time point, we maintain excellent correlation with the 3 time point gold standard. Encouragingly, the cumulative dose to the kidneys was maintained within 15% for all but 1 of the 158 kidneys, with a mean error of only 0.1 plus or minus 0.8 gray. So that's this curve here. And we can see it aligns very nicely. Removal of the 4-hour time point was somewhat less successful, with 10 out of 156 kidneys having a cumulative dose outside of 15% and an average deviation of negative 0.3 plus or minus 1.8 gray. So in conclusion, we've demonstrated that while 2 time point dosimetry looks to be a reasonable approach, 1 time point dosimetry has a very substantial bias towards overprediction. This might be because of the fact that the previous studies mostly suggested using a time point of 96 hours or greater to reduce the error, and we're using 72 hours because that's the data we had. But our error was slightly higher than those published in the report, which would have expected about 8% error where we see 11. As such, we would find that if we used one time point dosimetry, we'd be worried that we would have an under-treatment of our patients. Conversely, the removal of the 24-hour time point can be performed without significantly impacting either the cumulative injected activity, with only 1 out of 81 cases outside of 15%, or absorbed dose estimates to the kidneys, while only 1 in 158 of the kidneys had a dose greater than 15% more than the gold standard. Removal of the 24-hour time point can reduce patient burden and resource implications for individualized dosimetry as well. The 4-hour time point is very easy to obtain since the patient's already in the hospital for their injection. And this prevents the patient needing to come back from one of their 2 follow-up scans on the second day. This would cut the follow-up visits in half without significantly impacting the patient treatment. So finally, I'd like to acknowledge our entire QiPCM team. So our physicists, as well as research associates, program manager, and other research associates. The trial PA, Dr. Rebecca Wong, for forcing this trial through. It took about 5 years, I think, to actually get this through, this trial approved through Health Canada. And our nuclear medicine technologist on site, as well as the trial investigators and physicists, Stephen Breen, Troy Farncombe, Rob Sedilka, and Kathy Katinsky, as well as support from CanProbe in their development, and our funding sources at the OICR, CCO, Princess Margaret Cancer Foundation, and CHR. And this is a picture, it's pretty outdated. We were scheduled to have another picture on March 25th, and you can guess what happened with that. So I'm open for